going back to this guideline, which was never intended to be controversial at all, one of the things that we wanted to set out to do was to provide a guideline for people that treat depression, right? And it's a different world over there in people that never see substance use disorders, and it's much more conservative in terms of what they're willing to include. And so one of the strengths, I think, and also the weaknesses of the group was that they were world-leading experts in RTMS for depression, and at the same time, they naturally didn't have the same level of comfort of dealing with substance use that presents in the patient population. The other thing that we were trying to get was a kind of spectrum of substance use. And so, it's important to note that we weren't specifically looking at substance use disorder, like the DSM disorder, right? I think that there is a big difference between the pharmacological effect of alcohol, like having a drink, having 3 drinks, having 4, versus an alcohol use disorder, which, is mostly behavioral and psychological criteria of being unable to control the use. So anyway, it was a Delphi process. It's organized in kind of recommendations that are general and then specific to alcohol, cannabis, stimulants, and opioids. We made research recommendations, but they were put in the supplement because it was difficult to kind of make big consensuses on that. And it's hard to highlight everything, but some of the things that I wanted to note that we found as a group was that we do recommend that all RTMS practitioners use a standardized clinical tool to screen for substance use disorders, although there isn't a specific one that needs to be favored over another. Abstinence or reduction of a recreational substance use may be good, but abrupt or big changes to the baseline pattern of use could be risky, right? So while it is good to always recommend people to reduce their drinking, you don't want to tell them to go cold turkey and then show up to RTMS. That would be bad. And then to not categorically exclude all substance users. So, I think the truth is somewhere in between, right? And one of the big things that I noticed talking to practitioners of RTMS for depression alone is that it's just a categorical, black and white, don't even say the word substance, don't come through this door, right? And so we wanted to kind of gently soften that language and be like, well, probably mild use disorders are fine. Be worried about severe substance use disorders. But a lot of it comes down to a clinical assessment of truly what the severity is. And yeah, there was less certainty with unregulated drugs, non-oral routes like injection, and that we're missing a lot of evidence for comorbid conditions with substance use disorder specifically, but definitely research is required and kind of the focus of my research program, and I'm very hopeful for the potential of this in substance use disorders. But there were limitations, and I think I already mentioned most of them, and we'll speed this along for the interest of time. Okay, patient perspectives is important too. So we did a mixed methods study of patient acceptability and interest in RTMS specific for smoking, because I'm interested in substance use disorders. And we had 27 people complete semi-structured interviews after learning about RTMS for smoking. And one of the themes that came up was that people were really hoping for this killing 2 birds with 1 stone. So one quote is that RTMS started out as a depression treatment, and hopefully, and I have suffered from that in the past. Another participant said, I'm just going to skip to the highlight, I'm hoping to kill 2 birds with 1 stone. I don't know if it's the same as depression, but I know RTMS has helped people, including my sister, with depression. So, what we'll see is that patients have multiple things coming in, and we prescribe things that have a certain indication, but everybody has hopes that they just get better overall. And a better overall means a better of everything, right? Seizure risk. So like Hamid said, there's no reported seizures in any of the RTMS for SUD trials, so very, very exciting. There are case reports of seizures with substance use. So basically, case reports where there was a seizure, and then retrospectively they looked at the history and found that there was substance use, whether it was hidden or inadvertent or something like that. Case reports are limited, they only tell us so much. But I think one of the themes of a lot of these case reports was improper screening. So a lot of it was like they thought they didn't drink, and then it turned out there was something in the blood alcohol level on urine toxicology afterwards. And so it doesn't point to any particular culprit, except that we really need to screen and understand the patients, and that, again, especially for our mood disorders colleagues, like you have to think and screen about substance use. This is an interesting study looking at electrophysiological parameters with recreational substance use. So it was like nicotine, cannabis, alcohol. And there's a bunch of different experimental protocols to basically look at changes in cortical excitability with a single TMS pulse. And a lot of these are kind of experimental measures, but we use this thing called RMT, or resting motor threshold, to determine kind of the stimulation intensity. And what this systematic review found was that there was no changes in resting motor threshold for either alcohol, cannabis, nicotine, and I think they look at caffeine as well. And so basically what it shows is that we don't necessarily have to think that we need a higher energy or lower energy when it comes to people that have used substances. So yeah. At the same time, I mean, meta-analyses are a funny thing, and there definitely are individual studies that show that resting motor threshold can decrease if someone uses alcohol or increase if someone uses cocaine, and that usually relates to kind of alcohol being a depressant and thinking that it lowers the seizure threshold, and the other way around for cocaine use. And we did talk about motor threshold in the guideline, basically that acute intake of stimulants, acute intake of alcohol or acute withdrawal of stimulants may increase the risk increasing motor threshold, and the other way around for acute stimulants intake and acute alcohol withdrawal. And so alcohol and stimulants are something that we're particularly need to be mindful of in screening, and it's less known or less worried about when it comes to cannabis and opioids. So this is a conceptual framework that I like to use, which is this. So the bottom axis is like your daily RTMS treatments. And at the beginning of it, what you're trying to do is figure out the MT, or the motor threshold, which is like kind of the baseline, like the minimal level that it takes to activate the neurons, or at least the motor neurons in the brain. Then you deliver RTMS a little bit higher than that. So if you hear like 120% motor threshold, it's because you're going beyond that. And then the big risk is if you go way beyond that, then you're going to induce a seizure with higher and higher intensities. Now, things like alcohol may reduce the seizure threshold such that it kind of decreases stably like this if you have a stable level of alcohol use. And so one way to think about this is that the highest risk is in unstable and unpredictable use patterns, and that the risk state is mostly in intoxication withdrawal syndromes, because if you're in withdrawal, then you may lower the seizure threshold such that it dips below the stimulation intensity that you're currently stimulating at and then cause a seizure. And then if you're in an intoxicated state, it goes beyond that, and that's not a problem. But it becomes unpredictable, and usually when you should probably recheck a motor threshold or maybe even pause RTMS treatment is if they show up in that state. Yeah.
Go back to the prior slide.
Yeah.
Wouldn't it be higher, or the seizure threshold would be higher with alcohol, not lower, right? If you're drinking alcohol.
Oh, yeah, you're right, actually. It should be the other way around. Okay, so it'd be a stable level.
Withdrawal would lower the seizure threshold.
Withdrawal
lowers it. And most people are going to be in
Yes,
withdrawal
yes.
because their blood alcohol levels can be dropping while you're treating them.
That's when they show up, yeah.
Show up,
when they show up, yeah. So it's one way to think about dynamic assessments and day-to-day treatment assessments, which can honestly pose a challenge to TMS clinics, but definitely important if this is ultimately what we want to do and help people that are sick. We tried to run a trial on comorbid substance use and depression and suicidality, and one of the things that's a challenge in the field is the feasibility of bringing patients that have a severe substance use disorder as well as their kind of very chaotic lifestyles to adhere to these kind of rigorous treatment schedules that require travel and things like that. And so that's why it's really important to kind of figure out adaptive treatment schedules and more patient-oriented treatment schedules. So setting matters as well. So to reduce issues of dropout, we may have to think about where we're delivering our TMS. And as we all know, we can go from remote to outpatient clinic to intensive outpatient programs to inpatient hospitalization. And there have been RTMS studies across the spectrum of these treatment settings. But you can imagine that the safety risk is going to be completely different from an outpatient clinic to an intensive outpatient program to a rehab, right? And it's important to also look at protocols of the trials. Was this trial done in a residential setting or was it done in an outpatient setting? And both of these have been done, but these are some of the things that get lost when we bring everything into generalities, right? So for example, there are a lot of studies that come out of China where RTMS was delivered in like a compulsory treatment center. It was kind of like they had no choice but to be there, right? And so that's definitely a different setting. Okay, and then we published this paper kind of trying to make other recommendations on how we could implement this in rehab centers, like addiction treatment rehab centers. This was mostly like a narrative review and some opinion. But, you know, treatment centers should offer, addiction rehab centers should offer our TMS. With the caveat that we should require like some period of monitoring and stabilization. We have to make sure there's no signs or symptoms of withdrawal. And we want to make sure we perform more regular assessments of either substance use or changes in seizure threshold. But implementing this into residential treatment centers could be a big kind of access opening up for our patients, and a way to consider how we can bring this to patients with comorbidity and at the same time optimize the safety at the outset. And so that was kind of my bit. We're going to go back to the case vignette and then hopefully have a bit of discussion. Thanks.